Topic 4 addresses a primary service provider approach to teaming used in early intervention. In this topic, we will discuss how to use this type of teaming approach, the research behind it, as well as details about team meetings, which are a required component of the process. Teaming in early intervention is not a new concept. In fact, the use of teams has been a consistent component of the education legislation, recommended practice documents within and across disciplines, and the theoretical and research literature in early childhood and early intervention. Included in the federal legislation for Part C of the Individuals with Disabilities Education Act is a list of possible team members. Consider your program. How often do you access the different individuals on this list, as either part of your core team or extended team?
The literature references 3 different types of teaming models: multi, inter, and transdisciplinary. Think about the teams of which you have been a member. First, let's consider a multidisciplinary approach. In this teaming model, members function independent of one another. Each member develops his or her intervention plan and implements it with the child. The communication structure is typically informal and often depends on the parent to coordinate interactions and information. Teams functioning within an interdisciplinary approach report their professional perspectives to one another and carry out their part of the intervention plan independently. Members of the interdisciplinary team meet formally to share information related to child progress, challenges, and next steps. Transdisciplinary teams work collaboratively to create an intervention plan in which one member of the team will serve as the primary service provider and work directly with the child and family. Teams work through a process beginning with role extension to role release and finally role support to enable the primary service provider to work across typical discipline-specific boundaries.
When you think about the teams you've worked on in the past, whether multi, inter, or transdisciplinary, how would you improve team effectiveness and team collaboration?
In contrast to a transdisciplinary model of teaming, we have put forth a new alternative approach that fits more consistently with the mission and key principles for providing early intervention services in natural environments. This approach, simply called a primary service provider or primary coach approach to teaming, is different from a transdisciplinary model because both the way team members interact with one another and the practices used to support child growth and development are defined by specific evidence-based characteristics.
For information about the research-based characteristics of the primary service provider approach to teaming, follow this link for a brief article. Take a moment to read the definition of a primary service provider approach to teaming. We developed this definition based on elements of the research found to be effective in building the capacity of families and other care providers to support the growth and development of the children in their care.
This diagram illustrates the evidence-based approach to early intervention in the Babies Can't Wait program. Within the framework of evidence-based practices are 3 components necessary for operationalizing the mission and key principles for providing early intervention services in natural environments. The 3 components are coaching as the interaction style, natural learning environment practices in terms of where and how we promote child learning and development, and the use of a primary service provider approach to teaming. Since the adults in the child's life are critical in supporting the child's learning when the early intervention practitioners are not present, coaching is the interaction style used to build their current knowledge and skills as well as develop new abilities to promote child learning.
Natural learning environment practices support parents and other primary care providers in understanding the importance of everyday activities as the sources of interest-based children's learning opportunities. In order to implement natural learning environment practices with the least intrusion on family life, use of a primary service provider approach to teaming can result in positive outcomes for young children and their families. These practices are implemented when a program is identified as a formal resource for early intervention and family support and uses practitioners with diverse knowledge and experience to support the child's parents and other primary caregivers. The use of this teaming approach is not intended to limit a family's access to supports and services, but instead is intended to expand support for families by using core teams of individuals representing multiple disciplines who are accountable to the family as well as one another.
The framework for this evidence-based approach to early intervention is supported by the mission and key principles for providing early intervention services in natural environments. As we discussed at length in Topic 1, the mission of Part C Early Intervention is to build upon and support the capacity of the important people in the life of the child to promote child growth and development by supporting and enhancing everyday learning opportunities. To access the NECTAC Mission and Key Principles documents, follow the link at the bottom of this slide. First, let's consider the characteristic of a defined team. Abundant research exists on the effectiveness of teams across a variety of contexts, including education, early childhood, healthcare, business, and industry. In a meta-analysis of the teaming literature, Suzanne Bell in 2004 reported that specific task and structure factors exist that enhance effective delivery of services when teams are used. Every task and structure factor directly applies to the use of teams in early intervention, particularly those that use a primary service provider approach.
Secondly, the characteristic of selecting a primary service provider to serve as a team liaison to the family is the most controversial aspect of using this approach to teaming. Many practitioners and family members assume that this strategy is used to decrease services, thus decrease costs, and apply a predetermined limit to the amount and type of services for a particular child and family. This assumption cannot be further from the truth. The practice of selecting a single provider is based upon evidence. We will specifically mention 3 sizable studies that discourage the use of multiple providers and highlight the benefits of using a primary service provider. First, the work of Jack Shonkoff and colleagues in 1992 clearly describes positive outcomes for families and infants. This longitudinal study involved 190 infants and their families after the child had received 1 year of early intervention services. Results indicated that those families receiving their services from a single provider, as compared to families receiving services from multiple providers, reported less parenting stress. Additionally, the developmental outcomes for the infants of the families receiving services from a single provider were better than when the infant was receiving multidisciplinary services. These results persisted when the study controlled for the severity of disability of the child, the age of the child, and when both factors were controlled simultaneously. The only benefit actualized for the families of the children receiving services from multiple providers was an increase in the size of the mother's social support network. No differences were noted, however, in the mother's reports of the helpfulness of their social support networks.
In a review of the literature, also published in 1992, Patricia Sloper summarized that those families with multiple providers experienced increased parental stress, unmet needs, and confusion. What might come as a surprise to many practitioners is the finding that having multiple providers resulted in unmet needs for a significant number of families, and most of those families were of children with severe disabilities. This seems contrary to the commonly held belief that the needs of a child with severe disabilities cannot possibly be met by a primary service provider. In several studies reviewed, parents of children with disabilities reported confusion when multiple providers were involved on a regular basis. This confusion resulted from conflicting information and recommendations regarding intervention and resources. Parents were also confused about which practitioner to access regarding specific questions or supports needed. For example, it might be clear with the professionals working with the family who addresses what issues, but parents reported ongoing struggles with the role definitions when multiple providers were involved.
Another key set of findings is derived from the work of Dunst and colleagues in 1998. In this study of a statewide early intervention program, 250 parents completed surveys and follow-up parent and family outcome measures. This study examined the level of family-centered practices the family received and resulting benefits for the children and families. Results indicated that the more services that a family received, the less satisfied they were with early intervention, the less family-centered the respondents rated the program, and the more negative the effects on personal and family well-being. The families reported receipt of services that were not family-centered also reported less child progress.
Finally, another major contribution related to use of a primary service provider is the work of Mary Beth Bruder and Carl Dunst from the Research and Training Center on Service Coordination and Early Intervention. One particular study involved 80 parents from 4 states and controlled for family ethnicity, socioeconomic status, child severity of disability, and locations such as rural, urban, or suburban. Parents were interviewed about many aspects of their early intervention services and experience. Findings indicated that the more service providers involved with the family, the poorer the ratings of helpfulness reported by the family.
Based upon the research available, 3 characteristics define the use of a primary service provider approach to teaming: a defined team, identification of a primary service provider to support the child, family, and other care providers, and finally, the use of an interaction style, such as coaching, to support family members and other team members.
Let's discuss more specifically the concept of a defined team. The notion of a defined team, or one that does not change based upon child characteristics, can be a new concept for many practitioners. When using a primary service provider approach to teaming, a core team of professionals must minimally include the service coordinator, probably more than one, an early childhood special educator or early intervention specialist, an occupational therapist, physical therapist, and speech-language pathologist. This core team is then assigned to serve a designated region or area such as a county, school district, zip code area, or any other type of defined geographic region. If the district is fortunate to have available other service providers, such as infant mental health specialists, social workers, nurses, nutritionists, psychologists, or other specialists or consultants, these providers can also be considered as core team members and serve as the primary service provider for children and families within that defined geographic region.
One of the misperceptions about the use of a primary service provider teaming approach is the faulty notion that the child and family only get one provider. The concept is actually that the child and family get an entire team. The team, however, selects one person to serve as the primary provider or liaison from the rest of the team, and then as needs or questions arise, the primary provider will seek the support of the other team members to assist the child and family. This support can happen through team meetings, individual consultation, or consultative visits in which the primary provider and other team members visit together to work with the child and family.
As the primary service provider works with the child and family, he or she uses an interaction style to support the family members and other care providers in developing enhanced confidence and competence to support child learning, growth, and development. During team meetings, individual consultation, and consultative visits between the primary service provider and other team members, coaching is used to enhance the learning of all team members to ensure quality service provision for all children and families enrolled in the Babies Can't Wait program.
In order to effectively and efficiently implement a primary service provider approach to teaming, several implementation conditions exist. To maximize effective use of resources, all team members must be available to serve as the primary service provider. Sometimes teams feel that because a paucity of providers of a particular discipline exist, that those roles are best used in a supportive or consultative manner. This is not the case. Team resources are maximized and children and families' needs best met when therapists and educators are all available to serve in the capacity as a primary provider. Another requirement when implementing a primary service provider teaming approach is the attendance of all team members at the regular team meetings. The presence of all team members, either physically or virtually, is critical. The team meeting is the strategy used to support one another to ensure quality services for young children and their families. The multidisciplinary viewpoints are needed to consider all aspects of the child's development and the family's priorities.
Questions often arise about how a team selects the primary service provider. It is important to note that the family is involved in this decision, but during the process of the initial interview, evaluation, and assessment, teams are thinking about who should be involved based upon the child's needs, family's priorities, and who the most likely primary service provider might be. We've identified several key factors or filters to consider. We encourage teams to take a long-term perspective, considering the child's characteristics, including any predictive information we have about a specific condition or diagnosis. The concept is that over the time the child is enrolled in Part C, the primary service provider will change as little as possible, ideally not at all. The team member should consider the family's desired outcomes for the child, any needed specialized skills and knowledge, and a prior or developing relationship between a specific team member and the family. Finally, all things considered, the issues of team logistics and availability will also factor into the team's decision. Another implementation condition is the strategy of joint visits or consultative visits as they are named in Georgia. The consultative visits happen same day, same time, and serve as the mechanism for other team members to provide timely support to the child, family, and primary service provider.
Now that we've shared some basic information with you about the research, characteristics, and implementation conditions of a primary service provider approach to teaming, take a few minutes to think about how this approach is being implemented in your district. If you have questions, please talk with your early intervention coordinator or another team member. We encourage you to follow the link on this slide to the checklist for implementing a primary coach approach to teaming. This tool includes 4 checklists, one on preparing for implementing this approach, another on using a primary service provider, another on conducting joint or consultative visits, and the 4th checklist is all about team meetings. You can use this checklist to assess how your district is doing in terms of fidelity to the approach. If the approach is being implemented according to the research-based characteristics and implementation conditions, the answers to all indicators on all checklists is yes. If you identify some areas in which you cannot check yes, this would be a great conversation to have with your early intervention coordinator to consider your assessment and discuss strategies for improving implementation in your area.
In terms of exploring more information about consultative visits, we hope the checklist discussed in the previous slide was helpful for you. In addition, we encourage team members to consider specific times when a consultative visit should occur. One situation is when the primary service provider has questions that cannot be answered by other team members without eyes or hands on the child or direct observation in the child's home, childcare setting, or other natural environment. Another circumstance is when the other team members have questions for the primary provider that he or she cannot answer. Therefore, on-site observation is required. As well, it is essential that when parents request access to a team member other than the primary service provider, that access is granted in a timely and respected manner.
A consultative visit has 3 components when implemented according to the characteristics of the approach. In preparation for a consultative visit, the primary service provider should discuss the visit with the parent and plan for how best to use the time together. In addition to planning with the parents, the primary provider and secondary practitioner should also converse about the purpose of the visit and share needed information about parent priorities, child interests, and activity settings serving as the focus of intervention supports. Once this planning occurs, the consultative visit should happen, and then following the visit, a debriefing with both the parent and secondary provider should occur as soon as possible. This debriefing conversation is critical for developing a joint plan for implementation and joint planning.
We'd like you to watch the video of 2 early intervention practitioners planning for a consultative visit. Elizabeth, the early intervention specialist, is serving as the role as primary service provider, and Serena, the speech-language pathologist, will be joining her for a visit with a family in need of additional support. As you watch the video, think about the information that we've shared and consider the effectiveness of their planning conversation.
What did you think of the planning conversation for the consultative visit with Elizabeth and Serena? Take a few minutes to consider the indicators on the consultative visit checklist and how they compare with what you observed in the video. This checklist can be a helpful tool when learning how to conduct consultative visits, as well as assessing the effectiveness of the implementation condition of consultative visits. If you have the opportunity to observe a joint visit, take this checklist along for your own learning.
This slide provides you with links to additional resources for learning more about how to implement the evidence-based characteristics and implementation conditions for a primary service provider approach to teaming. Take some time to visit the fipcase.org website to learn more.
Now let's take a brief look at the team meeting as mentioned earlier in this topic. Team members may be present in person, by phone, or on the web, but must participate for the entire meeting. Team meetings should happen regularly, most often weekly, but not less than every other week. In our experience, the average length of team meetings is from 60 to 90 minutes. Don't panic. Every child enrolled in the program is not discussed at every team meeting. At the end of this section, we provide you with a resource for developing the agenda. It is important that parents are informed of the dates and times of team meetings and should be invited to participate if they would like to do so.
As we've mentioned before, team meetings are a critical aspect of effective implementation of a primary service provider approach to teaming. The team meeting, however, is one of the most expensive components of this approach. In order to maximize resources, we must be mindful of not wasting any of the precious time we have together at a team meeting. We recommend several strategies to tighten up team meetings to promote high-quality interactions that serve all team members' needs. The team meeting should have an assigned team leader with meeting facilitation skills. All team meetings should have a pre-published agenda, and as you can see on this slide, we not only recommend specific agenda items, but also the order in which they occur. Most importantly, team meeting is a time to coach and support one another, to build the capacity of individual team members, and enhance the overall effectiveness of the team.
The link at the bottom of this slide will guide you to several documents that provide great detail about team meetings, roles and responsibilities of team members, how to establish an agenda, and recommendations for team ground rules. Follow the link and take time to read the documents. Bring these documents with you to your team meetings and use them as a reminder or assessment of how your team is doing in terms of conducting effective team meetings.